that's a 67-year-old male, again a bifocal fracture, which almost always needs some kind of open reduction. And if you land up with open reduction of this kind of a fracture, so that's after traction table, one needs to accept this, I think. And I had to open this and effectively reduce it anatomically. So हे जे म्हणत होतो मी चेतन मी की on traction table I can still anteroposteriorly use the toy clip to grasp and compress the lateral fragments. And since I have opened everything up, multiple K wires, putting a DHS, and because there is a greater trochanter fragment, supplement or augment my DHS with a TSP. And that's how. So one can reconstruct the anatomy so well and hold it with multiple screws, multiple fixations, and have it till it heals so well. The great ability of DHS, it's still a gold standard, must never be forgotten. Thank you.
Always keep a TSP handy. Always keep a TSP handy.
Always keep a TSP handy is the okay. Yes, of course.
Reverse oblique DHS. This was the case in the reverse oblique. Because you are connected with.
More than reverse oblique, this was a bifocal. So I had to reduce the basal as well as trochanteric fracture. Would I do DHS? I would keep DHS and nail both handy, and depending on the comminution and trochanter position, I would use. Here I could win using a DHS and TSP. Ideally, only reverse oblique, I will not use a DHS. Only reverse oblique, isolated, interpolated.
The primary fracture line was more basis of
It
IP.
is actually a more unstable. It has got neck femur also. It has also a lateral wall fracture. It's a posterior medial fracture.
Sunil, the primary fracture line is what determines. The primary fracture line in this case was the basis cervical element. The secondary fracture line was the trochanteric element. So that reverse oblique is the primary fracture line.
Sunil, it succeeded, you think it is still not non-union?
Sorry, go again, sir. No, I succeed. No. What should be the message is the so.
Message is you succeeded so beautifully. You have anatomically reduced the fracture. The debate is whether it is subtroch or no.
No, it is not primarily
So that
subtroch.
is what is his debate.
Yeah. So primarily, Sunil, it is not subtroch. Primarily, it is an intracapsular with trochanteric comminution. If it would have been primarily a subtroch or reverse oblique and secondary extension into intracapsular, choice of implant is intraepidural.
So
I agree.
No, it is a Kyle's type 1. That means the neck femur and trochanter is the most unstable. So you are asking
I'm not saying it is not unstable. I'm saying that
No, pure DHS versus augmented DHS. Probably that could be the thing.
yeah. So if I would have used a nail, I would have again augmented that, of course.
Yeah. Last case.
Yes.
Yeah, last.
Only 4 minutes are left. Last.
So, presenting the case of this.
Yes, sir.
So, this was a 50 years old male who was a farmer. This was an initial fixation with DHS, and as we would agree, the fixation doesn't look good, the reduction doesn't look good, and there was no derotation screw. So, this was the picture after some months. And as you can see, 6 months post-op, there is a hollow around the screw. The screw is already giving way, there is non-union. So this is how the picture was. And this was 9 months post-op. The whole head, this is a void onto the superior aspect, and a 50 years old farmer. And as per the counseling sessions, he was not willing for orthoplasty, wanted to go ahead with the osteosynthesis. Have a close look at the femoral neck part. So this was managed with a fixation, osteotomy, fibula, and a cancellous bone graft. The cancellous bone grafts were pushed through the tract of DHS. Fibula was split and inserted in the superior part. This is healing at 4 months post-op. This is the healing phase. The osteotomy was gentle osteotomy, just a subtle osteotomy, not to valvulize more. And the proximal part of fibula healed well. The void has gone, and this is 5 years post-op. This is the lateral view, healed well completely, and a fantastic function, giving a very good result count.
Fantastic. So just one question on this case. While doing a valgus kind of an osteotomy, valgus abduction, do you always put in a fibular strut? Or
So my indication for putting a fibular strut is if there is a void in the part of neck or head or neck length is lost, fibula is useful too. If there is no void, fibula is not.
the consensus of the entire panel and seniors sitting in front of me as to what should be the choice of an implant for a valgus abduction osteotomy in a young non-union neck, because there are angle blade plates, double angle blade plates, the DHS, many options, which
I think pediatric DHS, which is occupying less amount of bone and taking less amount of bone out also, and supplement that with an additional screw. But the whole idea is to create valgus which will aid into healing. So that's my take. So not a double angle, a normal DHS, but a pediatric size.
sir,
Under DHS, because the purpose is to not medialize the shaft. You can do that and give the valgus osteotomy. I think this is good to me.
okay. Thank you very much. This was a very interesting hip session.